Right now, an invisible trap is being sprung in clinics all across the country. A completely healthy, active 74-year-old walks into a routine checkup feeling energetic, independent, and completely fine. They leave with a single, innocent-looking referral slip for a standard preventative screening. No big deal, right? Fast forward 6 months. That same individual is now managing 3 new specialists, dealing with severe complications from an invasive procedure, balancing 4 new prescriptions, and has become too terrified to leave the house. The original condition they were being screened for, it never would have touched them. It was the medical system that caught up with them. This is the hidden danger of the modern medical cascade, a devastating chain reaction where one well-intentioned test leads to an incidental finding, which triggers a biopsy, which causes a complication, which completely strips an older adult of their independence. I am Dr. Liam Cooper. Over my 2 decades in this field, I have seen the marvels of what modern medicine can achieve, but I have also stood at the bedsides of far too many patients who didn't need to be there. Patients who weren't broken by disease, but by a system that forgot to update its rulebook for the aging body. We have been conditioned to believe that more testing always equals more safety. But after the age of 60, the mathematical calculus of medicine fundamentally shifts, and almost no one is telling patients the truth. The exact same screening that buys a 50-year-old an extra 20 years of life might only buy a 75-year-old an extra 12 months. Months that are completely consumed by painful recovery rather than actual living. Today, we are pulling back the curtain on 6 specific medical screenings after 60, where the statistical risks now routinely outweigh the clinical benefits. This isn't anti-medicine. This is precise, high-level medicine designed to protect your dignity, your autonomy, and your quality of life. Let us begin. Let us begin with one of the most deeply entrenched procedures in preventative medicine, the routine screening colonoscopy. For decades, we have been told that this is the gold standard for catching colorectal cancer early. And for adults in their 50s and 60s, that statement is backed by rock-solid data. Finding and removing precancerous polyps in a 53-year-old genuinely saves lives, buying them decades of future health. But as you cross the threshold of 75, the biological and mathematical realities underlying this procedure undergo a massive silent shift. To understand why, we first have to look at the unique biology of colon cancer. It is among the slowest-moving malignancies known to science. On average, it takes anywhere from 10 to 15 years for a microscopic polyp to transform into a clinically dangerous, symptomatic cancer. Now do the math. If a routine colonoscopy flags a tiny, asymptomatic polyp in a 78-year-old today, the statistical probability of that polyp growing rapidly enough to impact their life expectancy is exceptionally low. Long before that tumor ever causes a single symptom, the patient will naturally pass away from entirely unrelated causes. Finding it doesn't save them. It merely converts a perfectly healthy person into a worried cancer patient and hands a specialist something to aggressively treat. While the potential benefit of this screening plummets to near zero as we age, the physical risks of the procedure itself skyrocket. The danger doesn't even start in the procedure room. It starts the night before, on your bathroom floor. The intensive bowel prep required to completely clear the colon is a massive physiological trauma for an older body. The severe forced diarrhea triggers rapid fluid loss, which frequently causes profound dehydration and critical electrolyte imbalances, such as severe drops in potassium and sodium. In a younger patient, this is a miserable inconvenience. In a 78-year-old whose kidney function is already naturally reduced by age, that level of dehydration can throw the body into acute kidney injury or trigger dangerous cardiac arrhythmias like atrial fibrillation. Then comes the sedation. The aging brain is uniquely vulnerable to anesthesia. Older adults metabolize sedative drugs much more slowly, and clinical literature shows a deeply troubling rate of postoperative cognitive decline and prolonged delirium in older patients following general or deep sedation. I have seen vibrant, sharp individuals take months to fully recover their mental baseline after a routine procedure, and some never quite get that sharpness back. Finally, there is the immediate structural risk, bowel perforation. As we age, the walls of the colon naturally become thinner, less elastic, and often riddled with tiny, fragile pockets known as diverticula. Pushing a rigid endoscope through this fragile tissue carries a real risk of tearing the bowel wall. A colonic perforation in a 45-year-old is a major emergency. In a frail 80-year-old, it requires immediate, high-risk open surgery, often resulting in a temporary or permanent colostomy bag, a catastrophic drop in mobility, and a high risk of life-threatening sepsis. The medical system, however, operates heavily on automated scheduling. When a patient hits a certain age, the computer flags them, a referral slip is automatically printed, and the patient is funneled toward the endoscopy suite. The major medical boards have recognized this systemic failure. The American Cancer Society and the U.S. Preventive Services Task Force explicitly updated their guidelines to state that routine colon cancer screening after age 75 should completely cease to be an automatic directive. Instead, it must be highly individualized, taking into rigorous account the patient's current health status, actual life expectancy, and personal values. Yet, in busy clinics, that nuanced conversation rarely happens because writing a referral takes 30 seconds, while explaining complex risk-benefit math takes 15 minutes that a doctor simply doesn't have. So, how do you protect yourself from being blindly pushed into this pipeline? You stop the automated process before it begins by asking your physician one critical question. If this test finds a small, slow-growing polyp today, are we realistically going to subject my body to aggressive surgery or chemotherapy to remove it? If the honest clinical answer is no, because the treatment would be far more dangerous than the condition itself, then you must ask a follow-up. Then why are we taking the structural and cognitive risks of doing this procedure in the first place? True preventative medicine after 75 means shifts its focus away from hunting down microscopic abnormalities that will never harm you. Instead, it prioritizes keeping your digestion functional, your kidneys protected, and your mind perfectly clear. Never allow an automated electronic medical record or a routine checklist to override the unique, delicate biology of your aging body. Demand the numbers, ask the questions, and evaluate the risks before you ever agree to pick up that prep kit. This next category is perhaps the most difficult to talk about, because cancer screening carries an immense emotional weight. The fear of cancer is deeply hardwired into us, and the instinct to hunt it down, catch it early, and eradicate it feels like the most responsible thing a human being can do. For decades, public health campaigns have pounded the message into our heads. Early detection saves lives. But over my 20 years as a physician, I have had to learn a deeply uncomfortable truth, and it is a truth that many doctors are still too afraid to say out loud. Finding a cancer and actually helping a patient are not always the same thing. Let us look first at the PSA, the prostate-specific antigen blood test, routinely ordered for men over 70. The fundamental flaw with using the PSA test as a routine blanket screening tool in older men is that prostate tissue naturally changes with age. As men get older, the prostate enlarges or develops minor, completely non-aggressive cellular changes that drive up that PSA number. The clinical reality is that the vast majority of prostate cancers detected in men over 70 are indolent, extraordinarily slow-growing tumors. In medical school, we are taught a blunt but highly accurate phrase for these. These are cancers you die with, not from. Statistically, an asymptomatic 75-year-old man with a low-grade prostate tumor will live out his natural life and pass away peacefully of something else entirely long before that tumor ever breaches the prostate capsule or causes a single symptom. But look at what happens the moment that routine blood test comes back with an elevated number. The psychological trap springs shut. You are told you have a borderline or suspicious result. The medical machinery starts accelerating at a speed that is almost impossible for a terrified patient to slow down. The next step is almost always a prostate biopsy. To get those tissue samples, a needle must be fired into the prostate multiple times. In an older body, this invasive procedure carries a high risk of localized bleeding and severe urinary tract infections that can quickly turn into life-threatening urosepsis. If that biopsy confirms a low-grade cancer, the pressure to treat becomes absolutely overwhelming. You are a human being. You hear the word cancer, and you want it out. But the treatments available, radical surgery, external beam radiation, or aggressive hormone deprivation therapy, carry a devastating price tag for an older adult. We are talking about permanent urinary incontinence, where you are forced to wear diapers for the rest of your life. We are talking about complete erectile dysfunction, profound chronic fatigue that robs you of your physical independence, and accelerated bone loss that sets you up for a catastrophic fracture. You have traded a quiet, harmless, microscopic cluster of cells for a treatment regime that actively dismantles your daily dignity and quality of life. This is exactly why the United States Preventive Services Task Force explicitly issued a Grade D recommendation against routine PSA screening for men aged 70 and older. The data proves unequivocally that the documented harms of routine screening in this age group heavily outweigh any potential survival benefit. Now, let us look at the exact same parallel in women. Routine screening mammography after age 75. The biological principle remains identical. Breast tissue in older women undergoes changes, and many of the tumors discovered on routine screening mammograms in women in their late 70s or 80s are highly indolent, hormone-sensitive, and incredibly slow-moving. Left entirely alone, they would never threaten that woman's life. Yet, once a mammogram identifies a shadow, the cascade activates. First comes the diagnostic mammogram, then the ultrasound, then the core needle biopsy. The emotional terror of waiting for these results inflicts a massive psychological toll on an older adult. If a microscopic cancer is found, the standard rigid treatment protocols are frequently deployed without accounting for age. A woman in her late 70s or 80s is suddenly wheeled into an operating room for a lumpectomy or mastectomy. She is subjected to weeks of targeted radiation or placed on long-term hormone-blocking medications that cause intense joint pain, severe hot flashes, and extreme fatigue. I have watched vibrant, independent women in their late 70s spend an entire year of their remaining life cycling through surgeries, surgical complications, wound healing issues, and exhausting hospital visits. An entire year of their life stolen by pain, limitation, and terrifying anxiety, all to treat a tiny localized tumor that statistically was never going to alter their lifespan by a single day. I want to be completely precise and clear here. This is not a blanket statement to ignore your body. If a man over 70 experiences new urinary retention or bone pain, or if a woman over 75 notices a visible lump, skin changes, or nipple discharge, those are clinical symptoms that demand immediate, thorough medical investigation. But that is diagnostic testing based on a real problem. What we are talking about reevaluating is screening, running asymptomatic, perfectly healthy older adults through a high-velocity cancer pipeline out of pure clinical habit. Before you automatically bop your head and agree to your next routine, PSA, or mammogram, you must break the clinical script. Look your doctor in the eye and ask these two precise questions. If this screening test flags a tiny, slow-growing cancer, what is the exact, real-world treatment path we will be forced to look down? And what are the realistic risks of that surgery or radiation on a body of my age and current health status? If the long-term side effects of the treatment will destroy the very independence and daily joy you currently enjoy, you have every right to say no to the screen. Real medicine after 70 recognizes that protecting the peace and functional capacity of your daily life is far more sacred than turning over every biological stone in search of a microscopic enemy that was never going to attack you. Let us shift our focus to the cardiovascular system and examine a test that carries an immense yet false sense of security. The routine cardiac stress test. The setup is highly familiar. You are placed on a treadmill with electrodes taped to your chest, and you are told to walk at progressively faster speeds and steeper inclines while a machine tracks your heart's electrical rhythm. If you cannot walk, they inject a powerful medication into your veins to chemically force your heart to race, simulating intense exercise. The intuitive logic behind this screening seems completely flawless. Heart disease is a leading killer. Therefore, forcing the heart under stress to catch a hidden blockage before it causes a massive heart attack feels like highly responsible proactive medicine. But when this test is deployed as a routine screening tool in adults over 70 who have absolutely no symptoms, meaning no chest pain, no tightness, no unexplainable shortness of breath, and no dizziness during daily activity, the mathematical and clinical reality completely falls apart. The fundamental flaw with routine stress testing in older adults is its staggeringly high false positive rate, which frequently ranges between 15% and 30%. As our blood vessels age, they naturally become stiffer and develop completely stable, calcified plaques. During a stress test, these completely normal, age-related vascular changes can cause minor, insignificant deviations on the electrocardiogram. The machine flags this as an abnormality or an ischemic change. The test does not say you are having a heart attack. It simply throws up a red flag. But once that red flag goes up in your medical chart, the psychological trap closes, and the heavy medical machinery accelerates. Your doctor feels legally and ethically terrified to leave that abnormal result alone, and you feel far too frightened to say no. The almost universal next step after a positive screening stress test is an invasive cardiac catheterization. This is an operative procedure where a specialist makes an incision in the artery of your groin or wrist and threads a long, thin plastic tube all the way up through your arterial system directly into your heart to inject a contrast dye. While the system treats a catheterization like a routine afternoon procedure, it carries severe elevated dangers for a body over 70. First, the heavy contrast dye injected into your system puts an immense physiological load on your kidneys. In an older adult whose baseline kidney function is already naturally declining, that dye load can instantly trigger acute kidney injury, forcing them into temporary or permanent renal failure. Second, threading a rigid catheter through older, brittle, plaque-lined arteries carries a real risk of scraping off a piece of cholesterol or tearing the blood vessel wall. If a piece of plaque is dislodged, it travels straight to the brain, causing the exact catastrophic stroke the medical system was supposedly trying to prevent. But the most devastating truth about this entire pipeline was uncovered by massive, multi-center clinical trials, including the landmark ischemia trial published in the New England Journal of Medicine. Researchers took thousands of patients with stable hidden coronary artery disease and divided them into two groups. One group received aggressive, invasive interventions like stenting or open-heart bypass surgery. The second group was left completely alone surgically and was managed simply with optimal standard medications like low-dose aspirin and statins. The long-term results sent shockwaves through the cardiothoracic community. For stable, asymptomatic patients, invading the body to mechanically open up those arteries produced the exact same outcomes as simply taking the right medications. Stenting, a silent, symptomless blockage, did not reduce the risk of a future heart attack, and it did not extend the patient's life by a single day. Think about the tragedy of that math. A perfectly functional 73-year-old accepts the immediate risks of bleeding, kidney failure, and procedural stroke during an invasive catheterization and stent placement, all to fix a silent blockage that clinical science proves could have been managed safely with a simple daily pill. What actually protects your heart after 60 is what has always worked. Rigorous blood pressure management, keeping your cholesterol in check, eating a nutrient-dense diet, and staying physically active. Your body's real-world capacity during daily life is a far more accurate gauge of your cardiac health than a high-stress treadmill protocol designed for a middle-aged population. If you are over 70, completely symptom-free, and your doctor hands you a referral for a routine cardiac stress test, you must intervene before the medical machinery takes over. Look directly at your physician and ask these precise questions. Since I can walk miles and climb stairs with zero chest pain or shortness of breath, what exactly are we trying to find on this treadmill? If the machine throws up a false positive flag, are we prepared to accept the real risks of a stroke or kidney failure in the cath lab just to treat a blockage that medication could manage just as effectively? True medicine after 70 respects the structural limits of your vascular system. It focuses on how your body actually feels and performs in your daily life, rather than forcing your heart into an artificial crisis that triggers a dangerous cascade of unneeded interventions. As we advance past the age of 80, the medical system frequently shifts its focus toward a devastating physical threat: hip and spinal fractures. And for good reason. A hip fracture in an octogenarian is an absolute medical catastrophe. Clinical data shows that up to 30% of adults over the age of 80 who suffer a hip fracture pass away within a single year due to related complications like immobility, blood clots, and pneumonia. To prevent these injuries, the medical system routinely deploys the DEXA scan, a dual-energy X-ray absorptiometry scan designed to measure bone mineral density. The scan itself is completely non-invasive, fast, and uses a very low dose of radiation. The concern is not the imaging table. The danger is the immediate, almost automatic prescription reflex that occurs the moment those numbers flash on a computer screen. When a DEXA scan evaluates the bones of an 81 or 82-year-old body, it almost universally reveals low bone density, slapping the patient with a formal diagnosis of osteoporosis. The standard guideline-driven response in a modern clinic is to immediately write a prescription for bisphosphonate medications. While these drugs can be highly beneficial when initiated at the right time in younger, postmenopausal populations, forcing them into a body over 80 introduces an incredibly complex and dangerous physiological equation. First, bisphosphonates are notoriously brutal on the gastrointestinal tract. They require the patient to sit completely upright for at least 30 to 60 minutes after swallowing the pill with a full glass of water without eating any food. For an older adult managing mobility issues or severe arthritis, this rigid routine is physically exhausting. Failing to follow it precisely can cause severe esophageal ulceration, leading to chronic bleeding, painful swallowing, and dangerous nutritional deficiencies. Second, the way these medications alter bone biology carries a terrifying paradox. Bisphosphonates work by shutting down osteoclasts, the cells responsible for breaking down old, worn-out bone tissue. By halting this breakdown, the medication causes bone matrix to accumulate, making the bone look thicker on a follow-up scan. But bone health isn't just about thickness, it is about flexibility. By preventing the body from clearing away old, micro-damaged bone, long-term use of these drugs creates bones that are increasingly brittle. Clinical literature documents a rare but catastrophic side effect known as an atypical femoral fracture. The patient is simply walking across their living room when their thigh bone, the strongest bone in the human body, spontaneously snaps in half due to the oversuppression of normal bone remodeling. A medication explicitly prescribed to prevent a bone fracture ends up causing one. But the most fundamental flaw with relying on a DEXA scan after 80 is that a bone density number does not measure your actual risk of breaking a bone. Think about this logically. A bone, no matter how thin or osteoporotic, does not break while you are lying safely in bed. It breaks when you lose your balance, trip over a rug, and slam into a hard floor. The root cause of a fracture in an octogenarian is almost never the structural density of the bone tissue itself. It is the physical event of the fall. And a DEXA scan will never tell you to clear clutter from your hallway or install a grab bar in your shower. It gives a busy doctor a number, and that number automatically triggers a chemical solution. When we look at decades of robust clinical evidence, the interventions that genuinely prevent fractures in older adults have nothing to do with a pharmacy. True fracture prevention means prioritizing dynamic muscle strength, intensive balance training, and meticulous home safety modifications. It means securing loose rugs, ensuring bright, adequate lighting for nighttime bathroom trips, installing non-slip mats, and systematically reviewing and eliminating medications that cause orthostatic hypotension or dizziness. It means ensuring adequate dietary protein intake to preserve lean muscle mass and maintaining optimal vitamin D levels to protect neurological coordination. If your physician suggests a routine DEXA scan, you must intervene to steer the clinical focus back to practical physics. Look at your doctor and ask these precise questions. Given my age, a number on a screen is going to tell us my bones are thinning. Instead of defaulting straight to a prescription that carries gastrointestinal risks and can make my bones more brittle over time, what are we doing right now to evaluate my physical strength and balance? Can we focus on a comprehensive fall prevention and home safety strategy first? True preventative medicine past 80 focuses on keeping your feet firmly planted on the ground. It recognizes that preserving your real-world stability, your leg strength, and your spatial awareness does infinitely more to protect your independence than chasing a theoretical T-score with a dangerous medication. Let us look closely at a preventative screening that sounds incredibly logical on paper, yet carries a hidden trap for the aging body: the routine carotid artery ultrasound. This is a non-invasive scan where a technician runs a probe over the sides of your neck to measure the blood flow through the major vessels supplying your brain. The rationale presented by the medical system is highly compelling. Strokes are devastating, and a primary cause of stroke is the buildup of fatty plaque in the carotid arteries. Therefore, scanning the neck of an asymptomatic older adult to catch a narrowing before it triggers a catastrophic stroke feels like the gold standard of responsible, proactive care. But when we look at the actual clinical evidence for adults over 70 who have absolutely no symptoms, meaning no history of a mini-stroke, no transient ischemic attacks, TIAs, no sudden weakness on one side of the body, and no abrupt changes in speech or vision, the risk-benefit equation undergoes a radical, dangerous reversal. As our bodies live through 7 or 8 decades, our arteries naturally develop some degree of narrowing and plaque buildup. If you run a carotid ultrasound on a healthy, symptom-free 74-year-old, it is incredibly common for the report to come back showing a significant blockage, such as a 70% or 80% narrowing on one side. The moment that percentage gets printed on a medical report, absolute alarm bells go off in the clinic. The patient is instantly referred to a vascular surgeon and a highly invasive procedure called a carotid endarterectomy, where a surgeon physically cuts open the neck artery to scrape out the plaque, or a carotid stenting procedure is put on the table. Here is the monumental truth that is rarely explained clearly to patients. For individuals with no stroke symptoms whatsoever, the evidence supporting these invasive procedures is remarkably weak. Multiple massive international clinical trials have shown that the immediate risk of suffering a catastrophic stroke during the operation itself frequently equals or completely exceeds the annual risk of simply leaving that stable blockage entirely alone. Read that again, because it exposes the ultimate tragedy of the medical cascade. The highly invasive surgery meant to protect you from a stroke is often the very event that causes the stroke. The aging vascular system is incredibly delicate. Forcing surgical instruments or a rigid stent into a brittle, plaque-lined carotid artery can dislodge a microscopic piece of debris, sending it straight into the brain's circulation, permanently paralyzing the patient on the operating table. Furthermore, modern pharmaceutical management has advanced dramatically. Decades of robust research prove that optimizing medications, specifically utilizing low-dose aspirin, advanced statin therapy to stabilize the plaque, and rigorous blood pressure control, achieves the exact same, or better, stroke prevention outcomes as a high-risk surgical intervention for asymptomatic narrowings, with zero risk of an operative disaster. This is precisely why the American Heart Association, the American Stroke Association, and the U.S. Preventive Services Task Force all issue clear, explicit guidelines stating that routine carotid artery screening in adults without symptoms is not recommended. Yet, because finding a narrowing feels like responsible medicine, thousands of these ultrasounds are ordered every single day out of clinical habit, funneling perfectly independent older adults into high-risk vascular surgeries they never needed. If your doctor suggests a routine ultrasound of your neck vessels and you have zero neurological symptoms, you must slow the process down before you find yourself booked for a surgical consultation. Ask your physician these direct high-level questions. Since I have never experienced a single symptom of a stroke or a TIA, what will an abnormal percentage on this ultrasound actually change in my daily care? If it shows a blockage, why would we risk the immediate, proven danger of a procedural stroke through surgery when optimal medication management is clinically proven to be just as effective and infinitely safer? Real medicine after 70 respects the stable adaptations your vascular system has made over a lifetime. It refuses to trade a calm, symptomless narrowing for a high-risk surgical procedure that threatens the very cognitive and physical independence you are trying to protect. We now arrive at our sixth and final screening, a procedure that demonstrates just how slowly the medical system updates its automatic protocols, the routine pap smear and cervical cancer screening for women past the age of 65. For decades, regular pelvic exams and cervical cytology have been a foundational component of women's preventive health care. This screening is incredibly effective at identifying high-risk human papillomavirus, HPV, strains and cellular changes before they can transform into invasive cervical cancer. For younger women, this test is undeniably a lifesaver. However, when a woman crosses the threshold of 65, the biological canvas shifts completely. Cervical cancer is a malignancy with an incredibly prolonged natural history. It typically takes anywhere from 15 to 20 years for a high-risk viral infection to progress into a dangerous, invasive tumor. If a woman has maintained a consistent history of normal, negative pap smears throughout her 40s, 50s, and early 60s, her biological risk of suddenly developing aggressive, life-threatening cervical cancer after 65 drops to near zero. Yet, because electronic health record systems are hardwired with automatic checkbox reminders, countless healthy women in their late 60s, 70s, and 80s are still handed referral slips for routine cervical screening every single year. While the statistical likelihood of this test finding a meaningful, life-threatening disease is virtually non-existent in this age group, the physical and psychological harms of continuing to screen are very real. The first issue is immediately physical. Following menopause, a woman's body undergoes natural, dramatic hormonal shifts. The severe drop in estrogen levels leads to progressive vaginal and vulvar tissue atrophy. The delicate mucous membranes become exceptionally thin, dry, and highly fragile. Performing a routine speculum exam on atrophic pelvic tissues is not just mildly uncomfortable, it can be excruciatingly painful. The physical trauma of inserting a rigid speculum and scraping the atrophic cervix with a plastic brush frequently causes immediate vaginal tearing, localized bleeding, and severe discomfort that can persist for days. The second major issue relates directly to the high rate of false positives caused by normal, age-related cellular changes. Because postmenopausal cervical tissue is thin and lacks estrogen stimulation, the cells often look highly distorted under a microscope. A pathologist viewing these atrophic cells will frequently flag them as atypical cells of undetermined significance, ASCUS, or low-grade squamous intraepithelial lesions. This is almost always a false alarm caused by a lack of estrogen, not by precancer. But the moment that abnormal label hits your medical chart, the high-velocity diagnostic cascade is triggered. To investigate that completely harmless age-related finding, you are funneled to a gynecologist for a colposcopy. This is a highly stressful procedure where the doctor applies a burning acetic acid solution to your internal tissues and uses sharp forceps to punch out multiple physical biopsies from your cervix. For an older woman, this invasive procedure carries a high risk of localized infection, prolonged vaginal bleeding, and intense physical pain. Waiting weeks for these surgical results inflicts a massive, unnecessary psychological toll. keeping you awake at 3 a.m., wondering if you have an advanced malignancy, when the truth is, your body was simply experiencing completely normal aging. The major medical authorities have recognized this structural failure for years. The U.S. Preventive Services Task Force explicitly issues a Grade D recommendation against routine cervical cancer screening in women over the age of 65, provided they have had adequate prior screening and are not at high risk. Despite these clear national guidelines, a massive gap persists between medical research and clinical habit. Busy clinics continue to order pap smears for asymptomatic older women simply because it is easier to click approve on a computer checklist than it is to sit down and review a patient's historical screening records. If you are over 65, have a history of normal pap smears, and your doctor attempts to schedule you for a routine screen, you must intervene before the diagnostic pipeline activates. Look your physician in the eye and ask these precise, evidence-based questions. Since I have a well-documented history of normal, negative screenings and no new clinical symptoms, what are we realistically hoping to find by scraping atrophic tissue today? Why are we risking the physical pain, vaginal trauma, and high probability of an age-related false positive when the national guidelines explicitly state, I should stop this screening? Real medicine past 65 means having the clinical maturity to leave healthy, normal tissues alone. It means refusing to subject your body to painful, invasive pelvic procedures to satisfy an outdated checkbox on a computer screen. Protect your physical comfort and your emotional peace of life by demanding a personalized evaluation before you ever agree to change into that hospital gown. What all of this comes down to is a profound shift in perspective. After a lifetime of trusting the medical system, it can feel incredibly intimidating to step back and ask these questions. You never want to seem difficult or appear as though you are refusing care. But let me be entirely clear. Asking your doctor for the numbers and the age-specific data is not resisting care. It is the most medically sophisticated thing you can do for your health. The system your physicians work in today was built for a younger population, and it has been painfully slow to update the rulebook. A typical clinic appointment lasts barely 15 minutes. Ordering a routine screening takes a doctor exactly 30 seconds. Having a nuanced, individualized conversation about whether that test makes sense for your specific biology takes 15 minutes that often do not exist. That is a systemic failure, but you can work around it. Bring a written list of these questions. Ask for a longer appointment block if you need it, and bring a trusted loved one to help advocate for you. Remember, more medicine is not always better medicine. After the age of 60, the ultimate goal of high-level healthcare must pivot away from obsessively hunting down every tiny biological wrinkle or microscopic abnormality on a scan. The real goal must be keeping you strong, clear-minded, mobile, independent, and living life entirely on your own terms. You are a person with a life, not a collection of data points on a laboratory report. Please note that the information provided throughout this video is for educational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Your individual history is unique, so before making any changes to your healthcare routine, please sit down and have a real conversation with your personal physician. If this video helped you think differently about your health, please smash that subscribe button, hit the like button, and drop a comment below sharing your own experiences with the medical cascade. Share this video with someone you care about, because this conversation is not happening nearly enough in waiting rooms today. I am Dr. Liam Cooper. Stay strong, stay informed, and stay in absolute charge of your own health. Take care, and I will see you in the next video.